Hello, and welcome to another episode of the Root of the Science podcast with your girl, Anne with an E. And today, Teresa, our show producer, is joining me once again as the co-host in the second part of the first episode of the polio eradication series in Nigeria. Welcome back, Teresa.
Thank you so much, Anne, and welcome to the continuation of our interview with Dr. Samuel Usman.
In the second part of our conversation with Dr. Samuel Usman, he will explore the crucial engagement strategies employed by the CORE Group Polio Project in Nigeria to eradicate polio. He will also discuss the role of traditional and religious leaders in vaccine campaigns and the essential involvement of women in the vaccine process.
Additionally, he will shed light on the complexities of maintaining the polio vaccine cold chain and the importance of accurate data in ensuring successful vaccination initiatives. Let's take a listen. So, I like the way that different sectors were involved in polio eradication, including even the locals, the community health volunteers, and also the traditional leaders. So speaking about the traditional leaders, you mentioned working with them. And so can you just explain how the CGPP facilitated work with the traditional leaders in terms of capacity building, training, in terms of resources, in terms of, yes, just getting them to understand polio first, and also how were they exactly involved in ensuring that this vaccine got to underserved children and communities?
Thank you, Teresa. Your question goes to the heart of the matter. When there's a problem, the best way to solve that problem is doing a root cause analysis that is going to the root cause of the problem. Now, the root cause of a lot of the issues the polio program had at that time was the fact that the religious and traditional leaders were not involved, neither were they engaged in the program. And that was why, like I mentioned when I was responding to Anne, some of the misconceptions, some of the misinformation, some of the disinformation originated or had their root causes from the religious and traditional leaders. And when CGPP did its own root cause analysis, in conjunction with other polio partners who are members of the National Polio Program, we realized that one of the lowest hanging fruits that we could quickly pluck, or we could quickly capitalize on, was engagement with religious and traditional leaders to get them to understand the benefits of the oral polio vaccine, to get them to understand that oral polio vaccine was safe, secure, and protective of their children. We needed to begin to engage them. And how did we facilitate that? We facilitated that through recruiting civil society organizations that were present in those areas where there were polio cases. And because civil society organizations are from that community, those civil society organizations developed what we call advocacy plans. Remember, I talked about one very important strategy of the secretary model, which I called ACSM, Advocacy, Communication, and Social Mobilization. So the A, which is the advocacy component, involves paying advocacy visits to religious and traditional data that we had mapped. So we did a very strong mapping. Who are the religious leaders in this community? Which sects do they belong to? Where are they located? Who are the most influential ones? Who are the ones that have the greatest followership and audience? Who are the ones that are most likely to say yes? Who are the ones that are most likely to say no? The ones that are most likely to say no, what do you need to tell them to begin to say yes? The ones that are sitting on the fence, how do we get them to sit on the side of accepting the vaccine? And like in Africa, in our part of the world, when a religious leader says this is what is good, people follow.
Yeah.
When purposely he says this is what is bad, people run away from that thing. So we needed to use people from those communities to develop advocacy plans. And those advocacy plans had to have well-crafted messages.
Mm.
And those well-crafted messages will be messages in the local language. For instance, if you speak Swahili, you won't go to a place and begin to speak Dutch. You only speak Swahili. So we had to get people who understand the local language to engage with these religious and traditional leaders in their local language, in their own context, which means you don't sit in another town and via phone call you are talking to the religious leader.
Yeah.
No, you go sit with him, dressing. And so we needed people from those communities to go and sit with the religious leader, speak the local language and tell him that, sir, this vaccine is safe. This vaccine is good. This and this and this is what the vaccine will do. The vaccine is not harmful. The vaccine is safe. The vaccine is protective. We know your children need to go to school. We know that your children need clothes. They need intestinal nets. But we show them pictures of children that have been paralyzed. We show them pictures. These children were paralyzed. Do you want your child to be like this? Do you want your grandchild to be like this? No. No parent. We want their child paralyzed. We show them videos. Occasionally, we have what we call polio survival groups, people that actually had polio and survived, and you can see the effects on them.
Wow.
They're paralyzed, they are crawling, but they are advocates of the vaccine. They say, look, this is how I am.
Yeah.
If I take a vaccine, I won't be like this. So that meant collaborating with other organizations like UNICEF. UNICEF had what they call polio survival groups that they were paying. We do more of the messaging. So it was a collaborative effort. Because one of the most critical strengths of the polio program is collaboration. So as civil society organization, we collaborate with UNICEF in doing advocacy to those religious leaders, telling them that, look, this thing is real. Don't believe these misconceptions. Don't believe these myths. This vaccine doesn't sterilize anybody. And we got some of the religious leaders to actually swallow the oral polio vaccine.
Oh, wow.
Yes, the Emir of Kano swallowed the oral polio vaccine. In one of the wards where we worked, Yadakunya in Kano State, he took the oral polio vaccine. This thing is safe. See, I'm taking it.
Yeah.
So we engage the religious traditional leaders through consistency of messaging, consistency of engagement, respectful engagement, cordial engagement, using the same language that they understand, meeting them in their locality with people that they know them, because the volunteers know this and they are respected. Those are some of the criteria we use to recruit the volunteers. They are responsible people, respectable people, people that are known in the environment, they are known in the community. So we did influence mapping as well. Who are the influential people that the religious leaders could also listen to? So we spoke to those people who are their peers.
Yeah.
So that those people can also serve as advocates to religious and traditional leaders. Because the main goal we wanted to achieve then was what? To build trust. Once you build trust in the vaccine, that is the entry point to the religious leaders accepting and telling their subjects, that's the entry point to the religious and traditional leaders accepting, and their subjects also accepting. So as we're talking to the religious leaders, we're talking to the traditional leaders. We're going to the palaces, talking to religious leaders, talking to that is why the emir could ingest the other polio, because he was convinced. Because people went to and told him, Your Highness, this thing is safe.
Yeah.
You have children, you have grandchildren. You don't want them to be paralyzed. So through this consistent engagement with the religious and traditional leaders, consistently, and also persistently, and also data-driven conversation in so place, so people were vaccinated. And so number of them were protected. So percentage were protected. Even when there were polio cases, those that were vaccinated were protected. Every pregnant woman that gives birth to a child, that child should be taken to the facility to receive the first dose of oral polio vaccine.
Yeah. Fantastic.
After 6 weeks, the child should receive another dose. So gradually, we built a groundswell of positive opinion about the vaccine amongst the religious and traditional leaders. So they became our champion. They became our advocates. So the dice flipped over, such that people that were initially at the forefront of rejection now became at the forefront of acceptance.
Yeah.
So when we now got them, then the rest was more or less easier to accomplish, because they began to tell their subjects during during mosque between religious and traditional leaders and the community. So that is where we began to build trust. And now we are trying to sustain that trust so that the children in those countries will continue to be vaccinated.
Amazing. What a wonderful strategy. You know, like you said, that these are the people who have the most important voice in the community, and really tackling the root cause there was so important. Just speaking on the idea of advocacy and, you know, having people in the community, it's also noted that the CGPP, they had a lot of women volunteers who really were part of the polio goal, eradication goal. Was this also intentional in the idea that having the women who are volunteers was also something that was really beneficial to reach the CGPP's goal in eradication of polio?
Thank you, Anne. That's a very, very important question. Yes, it was intentional. It was intentional because in the northern part of Nigeria, a male who doesn't belong to the family is not allowed to enter into another man's household.
Oh, wow.
So if you want volunteers that are trained to go from house to house to deliver messages that will build trust in the vaccine, that will make people to accept the vaccine, then you have to send people that will be allowed into the households. So the only gender that any man will allow to enter his household in his absence, if that person is not a member of his family, is a woman. So in order for us to be able to go to get people that will go house to house, different households regularly in a planned manner, is to recruit women. So we recruited women, trained them in social mobilization, train them in interpersonal communication skills, train them in the use of flip book, which is the book that contains pictorials that depict the oral polio vaccine being safe, that depict the life cycle of the virus, how it moves from stool to the mouth and the mouth to the abdomen and replicates and causes paralysis, to carry messages about the importance, because what we do is called convergent messaging. In those booklets, we don't only talk about polio, because polio is not the end of the world. We also talk about the importance of the woman attending regular antenatal care visits. We also talk about the importance of using insecticide-treated nets. We talk about the importance of using locally available food to prepare nutritious food that will keep the child nourished. So this convergent messaging was being done by women. So it was intentional. And permit me to say that currently we have 827 female volunteers in the program. And if you add the male peer educators and community informants that are another 2 separate cadre of volunteers, we have a total of 1,572.
Wow.
But the women are the bulk, 800. Like I told you, women are key, critical. and of paramount importance in our model. Because women are mothers, the fellow women in the household will listen to them.
Yeah.
So we have what we call compound meetings. A compound meeting is held when you have a cluster of women within a household, for example, who have issues about the vaccine that you need to clarify. So in the compound meeting, our female volunteers go into the household because they are not men, they are women. So the men, the household heads who are men do not complain. They say, oh, you are a woman. Okay, come into my house and talk to my wife. So they sit with the woman. They speak the local language. They listen to their concerns. And they address those concerns because we've trained them. So the female volunteers, I would say, are one of the game changers in the polio eradication initiative. Because they are examples as well of independent resourcefulness, because we train them. They are also examples of the fact that because they get stipends at the end of the month, that a woman has a potential to also be a breadwinner for the household. They are also examples of the fact that even though a woman is illiterate, in the sense that she's not going to a formal school, her capacity can still be built through local adult education systems that we use to train them. We use pictorials, we use demonstrations, we use different strategies, adult education strategies to build their capacity so that they know the case definition for acute flaccid paralysis. They understand how to administer the vaccine. They're able to administer the vaccine. They understand the technique because there's a technique behind it. They understand stage 1, 2, 3, and 4 of the oral polio vaccine. They know that stage 1 and 2 is only the one that can be given. Stage 3 and 4 are expired and cannot be given. We use pictorial to show them the different stages. We teach them the importance of keeping the vaccine in the proper cold atmosphere of the temperature required. That is, we teach them how to keep those vaccine boxes well. They have to have ice packs to keep the vaccine cold chain temperature standard so that the vaccine doesn't expire by going to stage 3 or 4. So we teach them the vaccine viral monitor, VVM. We teach them about the VVM. So at the end of the day, these people become a resource at the community level because they understand the program. They understand how to keep the vaccine. And sometimes when we have hesitancy or rejection, we have trained them, which we call non-compliance. We have trained them on how to address non-compliance. Non-compliance is when families and households do not want to comply with the vaccine. They say, no, we don't like the vaccine. Take your vaccine away for various reasons. So the women are significant human resource that we don't toy with. They are the foot soldiers. They are the advocacy champions. They are the face of the program at that level. They are the ones helping to sustain the tempo of the messaging. Because each volunteer has a register where she puts, they call it the microcensus. The microcensus is to enumerate, to number all the households in her own given settlement. Say there are 50 households, she'll number them 1, 2, 3, 4, 5 to 50. Now, in each household, she will go in and count, enumerate how many, because it's a polygamous setting, how many, okay, one husband, how many wives, how many of them are pregnant, how many children are 0 to 5 years in that house, because those are the ones that are eligible for oral polio vaccine. Do they have routine immunization cards? Are they taking Have they taken the necessary vaccine? Other than polio, the other vaccines, the routine vaccines, do they have their RI cards? Are the pregnant ones going for ANC? So that microcensus enables our volunteers to enumerate all of the households. So they use that to regularly monitor and track the messaging, because they go to the house. If they go yesterday, they go the next day, the woman begins to say something different. They know that something is wrong. Or if the woman that was pregnant last week has delivered, they see a baby, they say, oh, Mama, you've delivered. Oh, thank God. Now you need to take the child to the facility to get those birth shots.
Yeah.
The BCG and the other polio vaccine.
Mm.
So I tell people that our system is coordinated. It is locally driven.
Mm.
And importantly, has a feedback loop.
Mm.
Our volunteers are not just, giving messages, and not taking feedback. No, they also take feedback.
Mm.
Whatever feedback they take also gets to the top.
Amazing. What a wonderful role that they definitely play. Teresa, over to you.
Yes, and I also like the part where you say that as they do this work, they're also economically empowered, they're also trained. So that is also very important for the community. So, and again, you have mentioned that one of the important trainings that the community health workers go through is how to maintain the temperature of the vaccine, the required temperature, so that the vaccines remain potent. So, looking at that, these are rural areas. The northern part, some of them are very rural. So how have you been involved, the CGPP been involved in ensuring that the cold chain is maintained so that these vaccines are well preserved and then there's no wastage and they reach to the people they're supposed to get to while still very okay?
Thank you, Teresa. That's an excellent question. So, first off, CGPP is not in charge of the cold chain. What CGPP does is to ensure that all the regulations, the standard operating procedures in handling the vaccine, once the vaccine gets out of the cold chain, are maintained. And we also conduct what I will call spot checks, because let me quickly give an overview of the cold chain system in Nigeria. These vaccines come in via air transport. So they are brought into the country through aircrafts that have refrigerators, that have cold chain to keep the vaccine within the temperature that will ensure that it doesn't move out of stage 1. So they go to the National Strategic Cold Store, which is in Abuja, the federal capital. Then from Abuja, they go to the zonal cold stores. And like the name implies, they have the temperature equipment that keep the vaccine safe. Now from the zonal cold store, they now move to the states. Now from the state capital, they now go to the local government areas. The local government is supposed to have its own cold chain. That's how we have what we call the CCO, cold chain officer. We have that at the state level, we have at the LG. The LG level is like now, it is in those LG cold stores that our volunteers go to check and make sure that the vaccines are within the parameters in terms of the staging, and they've not gone beyond the normal stage. So our volunteers play the role of quality assurance to quality assure the cold chain system and ensure that there's light, because without electricity, the refrigerator is not powered. And that is what we also have, those that are solar powered. They call them SDDs, solar direct drive refrigerators. So they also check, because the solar direct drive refrigerator could be bad. That's why if you go to some of these LGs, you see that there's a roster of people who monitor the cold chain, and you see CGPP staff there. And government also knows that once these people are coming to check, then somebody there knows that she or he needs to sit up to ensure that the cold chain is working. And let me quickly give a short story. There was a time we went to one of our focal states. We went on advocacy visit to visit the executive secretary of the State Primary Healthcare Board. Because just like we have the National Primary Care Development Agency, that I said the EOC is embedded in, we also have the State Primary Healthcare agencies where the state EOC is embedded in. So we went to see the ES, and facilities in social location had no light for days. And the man went, "You mean it? No light?" And because when there's no light, the cold chain cannot work. Even though they have solar direct drive, but solar direct drive is full. So you must of necessity use the refrigerators that require electricity.
Mm.
The man started making phone calls there and then. He called the person, the CCO, the coaching officer. What is going on here? Why is there no light? They now discovered that this damn man didn't report.
Mm.
So you can see there was a chain reaction, a hierarchical decision-making process. Before you know it, people started talking. Root cause analysis was done. It was discovered that somebody got the money. He didn't do his job.
Mm.
He didn't get the person to fix the refrigerator. Before you know it, 2-3 days, it was resolved. So that's part of the critical role that CGPP plays as an advocate, as a quality assurance implementer, to ensure that we troubleshoot when the need arises, to guarantee and assure that the cold chain is at peak performance. And importantly, we also train our volunteers such that when they are given a vaccine that is not potent because it has moved out of stage 1 and 2, either stage 2 or stage 4, they don't accept it.
Mm-hmm.
Yes, because you are just collecting, maybe I'll just say something that is important.
Yeah.
Because stage 3 or 4 is useless. So why would they won't take it?
Mm.
They'll say, look, UVM is stage 3 or stage 4, so I won't take it.
Mm.
And automatically, when you see a vaccine that is in stage 3 or 4 is reportable, you report. They now begin to trace the batch number, who collected it, when did it leave the national strategic cold chain store, when did it get to the state cold chain store, when did it leave the cold chain store to the LGA cold chain store. Now, because I tell people the polio program is so organized.
Yeah.
So you now begin to track root cause. Where was the weak link where this thing could have gone bad? So our role, we don't buy the vaccines, we don't buy refrigerators, we're not responsible for providing light, but our role is quality assurance, which is key.
Mm. You can hear the efficiency, and that's something that you keep on saying in terms of this polio program. There's so much efficiency and almost in a military setting. And I think that's exactly why there's such success. So I just wanted to just comment that, really kudos to everyone who is part of this entire process, because I think if there were even small little gaps, we would have not gotten to where we are. But just the idea that from every single person who's involved in the team to the people who are on the ground, everybody is very efficient and they know exactly how things must be. So I just wanted to commend you on that. You can really hear that.
Thank you.
Oh, Chiza?
Okay. So I think this is a journey of a lot of discipline, a lot of accountability.
Yeah.
And if these things were not put in place, then probably someone would break the rules somewhere in the middle, and then you'd not be able to trace it, and then people would be affected, and then you lose vaccines. Yeah, something like that. So I am very impressed at these strategies of monitoring so it is a great journey. And so we are almost coming to an end of this, and I just want to ask you as we wrap up that so how does the CGPP measure the successes? What are some of the strategies that you put in place so that you're able to see this one went well, this one did not go well, what do we do next? So yes, so how do you record these successes?
Thank you very much, Teresa. That is an absolutely critical question. And it goes to the heart of polio eradication itself. Because polio being a disease that is eradicable, you need to be able to quantify the problem in order to be able to know the quantum of resources that are required to address the problem. If, for instance, the problem requires $1 million, but your data is showing a gap of $200,000, clearly there's a mismatch. So, in order for CGPP to properly understand the problem, the scope and size of the problem, before we start in any country, we do what we call baseline evaluation. We have a certain indicators that we measure to say what is the quantum of problem in this community. How many people, for instance, have been vaccinated with oral polio vaccine? What is the percentage? That's a baseline. At baseline, how many adults and caregivers have ever heard about the oral polio vaccine? Because if we have that baseline, we know that we can now say we know that 20% adults have heard. We now need to take that number to 60%. We know that XY% of children, maybe 10% of children have been vaccinated. We now need to take that number to what? To 20% or 30%. So that baseline is critical. And in that milieu, in that mix, we must have what we call indicators. Indicators that tell us the level of awareness, the level of coverage for particular vaccines, that is percentage of children vaccinated with that vaccine. And we also know the percentage of the population that are even eligible for the vaccine. Typically, like I mentioned before, children 0 to 5 years are eligible for the oral polio vaccine. But in terms of acute flaccid paralysis surveillance, you cover children 0 to 15 years.
Okay.
You want to know how many children are within the age range of 0 to 15 years.
Mm.
Then you want to know the population of under 5s in that locality. You want to know the total population in that community. So these are all the things we look at even as we're about to start. And like I told you, our goal is to contribute to polio eradication, by increasing population immunity and enhancing surveillance for acute flaccid paralysis. What that means is that because our goal is to increase population immunity, we begin to ask ourselves, what are those things we need to do? And we're talking about measurement now and tracking performance. What are those things we need to put in place to achieve the goal of increasing population immunity?
Mm.
I talked about the 4 pillars of polio eradication: strong routine immunization, supplemental immunization activities, acute flaccid paralysis surveillance, and outbreak response. Now, these 4 pillars, how many people do we need within CGPP to ensure that the areas where we work, we can do these 4 things? How much money do we need to do these 4 things? Which areas have the highest burden of polio? Which area have the highest number of missed children? These children that are eligible for the vaccine, but when the vaccinator goes there, they're not at home. We call them missed children.
Okay.
How many families have been consistently rejecting the vaccine? What we call non-compliance. Oh, no, I don't need the vaccine. I prefer ITN, net. My child has not eaten for 2 days. One of my children has malaria. I had to take her to the hospital yesterday. I don't have money to pay. You have been bringing vaccines to me. So how many people are non-compliant? How many people are even rejecting the vaccine outright? So with all of this, so polio is a data-driven intervention. So to have a comprehensive understanding of the community that we're going into. There's something to call data quality assessment. We do it on a half-yearly basis in CGPP. In every country program, you're supposed to, the DQA is to look at all the data collection tools. I told you our volunteers have registers, which they record. Now we look at the registers. The number of children you reported in the report, in the register, does it tally with what is in the register? You said you vaccinated 200 children. In the register, where is the evidence? You said out of 500 households, 200 they have routine immunization cards. We go and verify through random sample. So CGPP is a heavily data-focused intervention. And after the data quality assessment is done, we have what we call remediation action plan. We have a remediation action plan that lists where the gaps are, where the gap is, who is responsible for addressing the gap, what you need to address the gap, and the resource you need to address the gap. This is apart from what we call on-the-job monitoring and evaluation. What that means is that we have checklists. For instance, when I go to a facility, I have a checklist of important items that I need to see at the community level. For instance, our volunteers, they wear local dress. It has to be in a particular way to be acceptable to the community, so that we're not sending women that are half dressed to the community, which the community will reject. They also have to have a bag that contains their flip book, which is the educational material, their register, which is what they use to record. It has to have a pen. They don't use pencils, they use pen. It has to have what we call the AFP pictorial, which is a pictorial that shows what a paralyzed child looks like. Because you want to tell the man in the house or the woman in the house that you don't want your child to look like this. So the bag has to have 12 items in order for the bag to be complete in a manner that ensures that the volunteer is able to do her job properly. So we have a checklist that itemizes things that must be in that bag. We have a checklist that tells us what needs to be on ground when we go to the field. So at every level, we have checklists. We also do a lot of group work. For instance, we have what we call partners meeting. The partners meeting brings the secretariat, where the secretary director is, and she or he has technical officers that one for surveillance to ensure that surveillance is properly managed in the country program, the meal monitoring, evaluation, accountability, and to make sure that data collection, collation, and dissemination processes are properly in place. We have one for communication, that is the person that ensures that advocacy, communication, and social mobilization are being properly done. So we have officers, focal officers that anchor all of these different areas. We have somebody that manages global health security. So what happens is that each of these individuals has their own working group that they oversee. So that working group consists of the officers at the state level that have the same portfolio. So for instance, the social mobilization officer at the secretary has a social mobilization officer at the state level. So they have their small subgroups. These subgroups are for capacity building, to share lessons learned, to share challenges, and to jointly profile solutions that ensure that there is a shared understanding in addressing the problem. So this community officer at secretariat level is not talking down the person at the state level or the person at the community level, because the person at the community level, the person who is seeing the problem. You cannot, in another town, understand the problem more than the person who is seeing the problem on a day-to-day basis. So we have a lot of emphasis on reports. The reports are generated, of course, from the community level. From community level, you go to the LG level, we have what we call LGA coordinators who coordinate the local government area. And the local government area has wards and communities under it. At the community level, you have the volunteers. At the community level, a tier above that is the ward, where you have the ward volunteer ward supervisor who supervises the volunteers. Each supervisor supervises at about 10 to 12 volunteers. Then on top of the ward is the LGA level. So community, ward, LGA. LGA level, we have the LGA coordinator who coordinates the LGA. So she or he coordinates all of the wards in that LGA. And then the different wards have their supervisor who coordinate the volunteers in the community. So from the LGA level, the data now goes to the state level. From the state where the program office is, they evaluate the data, they crunch the data, they look at, okay, how many non-compliant households are here? That is, how many households are rejecting the vaccine? How many households are accepting the vaccine? This household has been consistently rejecting the vaccine for the last 6 months. What is the problem? Okay, somebody in the state team, we call the LGA coordinator. Did the ward supervisor go and see the volunteer? Yes, he did. What would the volunteer say was the problem? The volunteer said the man said he doesn't want to take. Okay, you need to ensure that that house is visited. So somebody from the state who has higher capacity will go to the LG, join the LG, and they go to the household. So you now have people who have more capacity than the volunteer, who have more skill in addressing the problem to go and talk to the household.
Mm.
So you can see the hierarchy of decision making, driven by data. So it's not a question of conjuring numbers and the numbers don't make sense. No, at every point in time, we are asking questions. Is this really true? If it is true, show us the evidence when you go to when you go to the community to see the registers. And we have smartphones. So each volunteer, like I said, the volunteer ward supervisor oversees about 10 to 12 volunteers. So the 10 to 12 volunteers that have the register, they collate their data on a weekly basis. So the ward supervisor has one paper where he aggregates all of the numbers from the 10 to 12 volunteers. So that's what is called tally sheet. The tally, that is, she or he tallies all of the numbers from the volunteers. So that tallied number is now uploaded into a smartphone. The smartphone is ODK enabled. ODK is a software, is Open Data Kit. So that Open Data Kit is connected to an ODK server from the phone server. Then at the national level, our monitoring, evaluation, accountability, and learning manager will now harvest the data from all the states into download the data. And from there, they can now analyze the data.
So thorough. So thorough. And very, very well tracked, data-driven strategies and implementation. Thank you so much, Dr. Samuel. We've gone through a really wonderful journey of learning everything that you do. And it's been so interesting. I know for me, as well as for, I'm sure, the listeners who are going to listen to this, it was such a pleasure having you on. And also, Teresa, thank you so much for joining me today and really holding the helms of this interview with me today. It was such a pleasure.
Thank you. Thank you so much, Anne. And thank you so much, Dr. Samuel, for being here. And we've had a really, really wonderful conversation. And I must say that the story of polio eradication in Nigeria is a very good story. It's a very good story with different angles. And yes, thank you so much for being here. And thank you also, Anne, for having me as a co-host today.
Thank you. And to everybody else who's tuned in, we hope that you learned something, and we'll catch you next time. Goodbye.
Bye. Thank you.